is a pulse rate that is around 70, 73, a saturation of 98, 99%, and very high blood pressures, 216 by 120 with a map of 155. Okay, this is what we're looking at. Now let's go to the pulsations here. The pulsations over here are very well felt, whereas pulsations over here are not felt. There are no pulsations over here. Patient is having abdomen pain, and we have started this patient on medicine. This patient has come only 5 minutes ago. We've started this patient on labetalol 250 cc and max dose to around 35, and we have reached 25 milligrams of an NTG over here. Come. This is a case of because of the tearing pain that he has, plus patient has got a mesenteric, probably patient has abdomen pain, plus patient has got absent pulses, okay, and plus the creatinine has gone up with the loin pain that is again and again complaining. This patient is a case of type, is a case of aortic dissection in the first place. We've just done a CT, we've done a CT aortogram, and we know that the dissection flap is arising below, from lower down. Type A is when it comes from the ascending aorta, and type B is when it comes below that, okay, from below the arch. That's what it is. So that's got the point below the ascending aorta. So it's a type B. Type A is an acute emergency. A is for acute. Patient needs to go for surgery. Type B is something that can be managed by medical management and by endovascular repair. Now, why does this patient require an endovascular repair? The patient requires an endovascular repair because patient is showing signs of mesenteric ischemia, as well as showing signs of thrombosis in the legs, which basically indicates that dissection flap has gone and caused renal artery thrombosis, mesenteric artery thrombosis, as well as dissection of the femoral veins. How do I titrate it? So what is the most important thing over here is medical management. The medical management involves three things. I'll show this over here. So is first starting labetalol. When you start labetalol, start this patient immediately at a 20 milligram bolus dose of labetalol and keep increasing it 20, 40, 80 every 5 minutes, 5 to 10 minutes. Increase it, make it 80 milligrams. And then you put 200 milligrams of labetalol in 50 cc of normal saline and start a dose of 0.5 to 1 milligram per minute. It is not a kilogram per minute, it's milligram per minute. So when you say 1 milligram per minute, you are looking at somewhere around 60 milligrams per hour. So 60 milligrams per hour in this case will be somewhere around 7.5 ml per hour. 7.5 ml per hour, titrate every 15 minutes up to 30 ml per hour. We have reached 25 ml per hour and still we don't see any change in pulse rate or BP. You keep titrating it till the systolic blood pressure is less than 100 or the heart rate is less than 55. This is the ones we want over here. Apart from this, one of the most important thing you should start is 500 microgram of fentanyl in 50 cc of normal saline at say 10 ml per hour and titrate it for pain relief. Titrate for pain relief. Normally when you start this, the back pain that he is having, the abdomen pain that he is having will actually start coming down and the BP will come down. Remember this, do not start the next antihypertensive agent, NTG or SNP for that matter, unless and until you have achieved maximum beta blocker and pain relief. Most important. Okay. Because why? Because the moment you start SNP or NTG, any of these things, there is going to be a reflex tachycardia, and that reflex tachycardia will cause the dissection flap to increase. And that is the reason that you first maximize this and then you start the patient on say SNP or NTG. SNP in this case can be problematic because the creatinine is already 2.4, 2.5. So this is known to cause thiocyanate toxicity and other related problems. And that is why 25 milligrams in SNP in 50 ml, though I would want to give this up to 15 ml per hour, 0.3 microgram per kilogram per minute is the dose. I will start at 2.5 ml per hour and go maximum to 10 ml per hour. Actually, I can go up to 15 to 20 ml per hour with this kind of SNP. But I will go from 2.5 to maximum 10 ml per hour in view of renal insufficiency. I'll start NTG 25 milligrams in 50 ml, 5% dextrose, go to 1.2 ml per hour up to 24, though I could go up to 48, up to 50 ml per hour. Okay, but 1.2 to 24 because I know there's no reflex tachycardia over here. And importantly, because there is hypertensive urgency which is not getting controlled with BP medicines, the next step is as quickly as possible to do TEVAR, which means transcutaneous endovascular aortic repair. Okay, this is what is very, very important in these cases where emergency stent aortic graft is put so that we are able to get around the dissection. Importantly, three things: control pain, control blood pressure with beta blocker to the maximum, then start NTG and start SNP. Clear? That's the management of aortic dissection in such cases. Okay, and this is a life-threatening emergency. On on the arterial line is also very interesting. What you see in the arterial line is a BP, systolic BP that is very high, and the diastolic BP that is very low. The pulse pressure that you are getting 200 is around 100. The difference between the systolic and the diastolic is somewhere around 110, which basically indicates extreme amount of afterload. Extreme amount of afterload, and the ventricle is actually pushing hard. How do you know it's pushing hard? Because you see that the dP by dt or the rise of the upstroke is very, very steep, indicating that the ventricle is pushing very, very hard. Also, this very big difference between the systolic and diastolic indicates probable aortic regurgitation, AR. This can occur, that's why the pulse pressure is varying so much, by more than 100. Okay, so the arterial line also gives an important clue to you as to what is happening over here. Importantly, again I repeat, the treatment remains labetalol, max doses, fentanyl, reduction of pain, and get the BP to as low as 120 to less than 100, in fact, around 100 with a pulse rate of more than 55. That's the management of aortic dissection with quick endovascular effect. Okay? Yeah.